Speaker is Dr. Stephen McLean, who hails from High Ridge, Missouri, where he graduated from the University of Missouri and trained at University of Vermont with Dermatopathology Fellowship at New York University. He's an associate professor of dermatology and emergency medicine at SUNY, which is Stony Brook, with research interests in wound healing, malignant melanoma, and pathology informatics. He practices dermatopathology and has his own lab called McLean Laboratories. Most recent work, thickness of normal toenails. At this point, we are going to ask for the topic, wound science, delayed healing in normal and diabetic skin. Please welcome Dr. Stephen McLean.
Good afternoon. I am going to talk about delayed healing, and they didn't even start the timer here, so I got a few extra minutes, it looks like. Okay. I have no financial interests. I want you to learn something about normal wound healing principles, be able to define delayed wound healing in normal and diabetic skin. I want to look at some diabetic healing in animals versus non-healing ulcers versus necrobiosis lipoidica diabeticorum. And I would urge you as trainees not to use the acronyms. Learn and own the diagnosis, necrobiosis lipoidica diabeticorum. You will wow any number of people when you learn that diagnosis. Explain doxycycline as a collagenase inhibitor. It's an underutilized property of the tetracyclines. Described a historical treatment for fungal ulcer, and develop an approach to improve pathologic study in these abnormal healing. I put on 5 references. One is about the standard of care being 15 days to 50% healing by Ambrose Paré, 1553. All gangrene is infected by Frederick Mohs in 1941. I have a notion hospital gangrene is aggravated or produced by fungi by Henry Van Dyke Carter in 1861. Some work on doxycycline as collagenase inhibitors. And I wanted to let you know that there's more than 200 clinical trials on tetracyclines in progress worldwide right now, 150 of which are in the U.S. This is available freely. In fact, all these references, if you email me, I'll send them to you. Okay, here we go. You need your seat belts on, your tray tables up, and your seats in their full upright position because we're going to go quickly. Yes, I did all those things, and I have an interest in wound healing. What we do in our laboratory is we make diagnosis with photographic proof, and so I show pictures. And I'd like to address my comments today to the podiatric surgeons in particular, because the problem we're going to talk about requires surgery. And I'm going to ask you specifically at the end of the lecture, will you invite pathology to the wound healing team? And it's pretty simple to do. You just send all your debridements and formalin to the path lab. Not the stuff you're going to put in microculture, but even the necrotic tissue. I want you to do that. And just say, rule out infection. You can ask specifically if you want for a PAS and an Alcian blue and a gram stain. And there's 5 components in those in that set, plus the H&E. I'm going to show you some data that I don't think is anywhere else in the literature because this hasn't been talked about for about 70 years. But this is the stuff on top of an ulcer. Okay, this was scraped off. This is not biofilm. This is hard. This is a callus. It's composed of cornified cells and all kinds of microbes. It's not a biofilm. It's a structure, and it's hard to get rid of. If we look at it under the microscope, there's parakeratosis. It's layered. Look at it by gram stain. Look at all these layers. It looks like the geology of the Grand Canyon or something. You've got blue layers, yellow layers, red layers, blue, purple, white. Every single one of, whoops, what happened here? Every single one of those, that's a structure being built up through a proliferation of cornified cells, infected cornified cells, in my opinion. Here's the layering. There's a network. Notice this cleft down here. Look at these things. How about these? Budding yeast. This is candida in a foot ulcer. And if you treat the fungus in a candida foot ulcer, you know what happens? They improve. Healing is normal. Non-healing is abnormal. It has a cause. And I hope that you will adopt that mentality that non-healing has a cause and you need to treat it. If you go after that cause and treat it, your care will improve. This is the animal studies I'm going to show you. These are rats, 6 millimeter punch biopsies. This is an acute diabetic model. Glucose is 400 to 600, and this is the human. They don't look anything alike. In fact, from this kind of work, all the wound researchers would say, you need a moist wound healing environment and so on, except it doesn't work in these. When you put these on, then something like this white tissue happens. Notice this looks like a sheet of skin has peeled off of here. We'll look at that in a minute. But notice this yellow structure here. It's the same thing we just looked at microscopically. Much different than the rat wounds. Maceration. Maceration is fungal. When you peel that stuff off and send it to the laboratory, you can see the hyphae in here and gloms of immature fungi, these yellow cheesy parts here. Okay, non-healing differs from delayed healing in diabetes mellitus. And human ulcers differ from animal research wounds. How? Well, none of these heal spontaneously, or practically none. These all are chronic diabetes, not 3 weeks of diabetes in an animal. And in my experience, now I only have about 250 cases, but 70% of them have fungi in them. Okay. Now, the other little known piece that doesn't happen in the rats is most rats do not have 80% toe fungus like the diabetics. They already have, many diabetics have an established fungal infection in the adjacent tissue, in the toenails. But you won't find this in the literature. Fungus and ulcer, you won't find it for practically since antibiotics came out in 1949. There is a paper on treating candida, when you culture candida, and they treated them and they got better. But the recent wound healing literature, for example, Dr. Tom Serena, no mention of fungus. We have to go back a ways to find this. We could go back to Ambroise Paré, and why would you go back to him? I suppose you could go back to him because he was a man of courage and conviction. You could go back to him because he was a barber surgeon. He was the leading surgeon in France at the time, probably all of Europe. His daddy was a barber surgeon, his uncle was a barber surgeon, his grandpa was a barber surgeon, and 2 of his brothers were barber surgeons. He was not an MD, he was not a surgeon, but he became the best-known surgeon in Europe in the 1500s. His description exactly that these callus ulcers are sordid, hollow, hard callus, round but not simple, complicated. He said, and the method to cure them, if cured, it can be, okay, if there's blood flow, these can be cured. Okay. Henry Van Dyke Carter described mycetoma, or the fungal disease of India, in 1860. And a year later, he followed up with another paper on mycetoma, and he has a note in there. I have a notion that hospital gangrene is caused or exacerbated by fungus, 1861. In 1874, he described something, the red fungus, that grew out of these wounds. Okay. 1908, Leo Berger of Mount Sinai Hospital in Manhattan described thromboangiitis or thromboangiitis obliterans. 8 years later, he followed up with a paper and said, I think all these are fungal. Frederick Mohs of Mohs Surgery 1941, he said all gangrene was infected, and I'll show you some of his data. And finally, Kenneth Thompson in 1944 described leg ulcers, venous leg ulcers, as surely fungal. How did he know that? He did 5 cultures in every wound. 5. He cleaned them off, he scraped them down, and then he took his samples. 5 samples. Okay? The yield in cultures is low. It's somewhere around 20 to 40%, depending on your technique. Okay, let's see. Let's begin at the beginning. So we're going to quickly go through wound healing and normal. There's the epidermis. It has a cornified layer, a granular zone. This part in the middle is the spinous zone, and then there's a basal layer. And inside there are nerve fibers, Langerhans cells, which are the immune-presenting cells, Merkel cells, the pressure receptors, and melanocytes. In the dermis, there's type 1 and type 2 collagen. There's a superficial plexus and a deep plexus. And the basement membrane is made up of type 4 collagen. All a review for you, I'm sure, but hair follicles, sebaceous lobules, and the eccrine glands are all important in wound healing, as we'll talk about in a minute. In the pathology laboratory, in our laboratory, we photograph every specimen. So this is how it looks after it comes out of formalin. This was where the shave biopsy was made, and then they did a re-excision. And so my job now is to make sure, is the cancer out? Are the margins clear? Is there any cancer even present? So we ink it blue on one side and kind of purple-red on the other, and then we slice it about every 3 millimeters. And we'll take a look at this particular slice in the next slide. It's day 16. Here's reepithelialization. This tongue comes down along here, but this is fibrin and red blood cells. This is reepithelialization proceeding from this side. But there's red blood cells, there's fibrin, and here's your early scar that's forming right down here at the base. I don't think that adds anything except you can see the tongue of reepithelialization. So these cells crawl out and proliferate out of the eccrine ducts and produce this new epidermis. Okay? Diabetic skin and all skin heals from below. The epidermis is said to regenerate from hair follicles, eccrine ducts, and if those are completely destroyed, then it has to crawl in from the sides, and that's a slow process. So deep wounds where these structures are destroyed, it's a problem. It's a slower healing. So a deep wound is delayed healing in many ways, unless you cut it out and bring the edges together. Whoops. The dermis is repaired. It's patched by granulation tissue, which produces scar. Granulation tissue is made up of 3 parts: endothelial cells, fibrocytes or fibroblasts, and the extracellular matrix. These cells crawl into the fibrin and platelets, and that's the first matrix, and soon they produce mucin or hyaluronic acid. Then they produce soluble collagen, goes outside the cell, cross-links, and becomes scar. The mesenchymal stem cells, I wrote a paper on this in 1996, the mesenchymal stem cells in deep wounds are in the subcutaneous fat. So as long as there's fat still present there, you can grow a new dermis, at least a scarred dermis. Let's talk about impaired wound healing in the general population. Age is important, especially sex hormones, testosterone and estrogen. Nutritional deficiencies are important. Vitamins B, C, and zinc, and protein malnutrition, all those things lead to delayed healing. Smoking is bad. I'll just leave it at that. Medications, especially steroids, delay healing. Now, there's local diseases that have impaired healing. Look at all these infections: MRSA, Pseudomonas, tinea, Candida, herpes, leprosy, mycetoma. And Aldo Castellani described cases of diphtheria, where there was a foot ulcer with diphtheria. They had clinical diphtheria. Now, this was 110 years ago. Diphtheria, clinical diphtheria with a foot ulcer. So there's a variety of organisms that can inhabit a wound, or you can develop a chronic infection and an ulcer. Abscesses have, for the past hundreds of years, required drainage. They don't heal well. Those will break open again and again until the abscess is drained. Foreign body granulomas or suture granulomas don't heal well. Thermal burns, chemical burns. Phenol is probably the most common harsh chemical that is used in clinical practice. And a deep phenol burn, that goes right through. And that chemical stays and it burns and it burns and it burns. They're hard to wash out because it binds to tissue. Prior radiation is delayed. Necrobiosis lipoidica diabeticorum. And cancer. Cancer can present as a non-healing sore. So if you think it looks like cancer, it needs to be biopsied. In our state, in this state, there are plenty of malpractice attorneys who will find you if you miss the cancer. Okay, how do we define delayed healing? Let's look at 1553 Ambroise-Paré versus 2012. Paré defined optimal treatment or optimal healing. He promised a patient with an ulcer to expect 50% closure in 15 days. Do you guys make promises like that to your patients? No, right? But he had an educated patient. He educated the patient and he treated him. That is a heroic tale, and someday maybe we can talk about it over a cool beverage tonight, the story of Ambroise-Paré. But 2012, we call it 50% closure in 30 days is delayed. So think about this. He's expecting closure by 50% in 15 days versus we're going to define when we failed. One's a positive definition and the other's a negative. And many of the European studies will use 100% healing in 90 days. If it's not healed by 90 days, it's delayed. Okay. How do you treat delayed healing in leg ulcer? Well, let's look at Ambroise-Paré. He was the surgeon to 4 French kings. He couldn't pay for his board examination, so he went in the army. Sound familiar to any of you? He went in the army and he became one of the best known surgeons. He was a bright guy. But when he made that promise, he put an obligation on the patient. You must do all that I ask, including bed rest, including compression dressings, including purgatives. He gave mercury. They really cleaned you out in those days from stem to stern when they treated you. Metal salt fixation. We're talking lead, mercury. We're talking harsh metals. This will fix tissue. Okay? And his definition of good wound care was to debride all which does not belong, whether it's on the foot. If it's not native to the foot, you should take it off. Get rid of it completely. And he used a general antiseptic of red wine. You think there's tannins in there? Oak tannins by any chance? Vinegar and saffron dye, a red dye. And red dyes were used for 500 years in treating ulcers. Okay. And he said, according to Galen, some 1,500 years before, medicines should remain in prolonged contact with the wound to allow their effect to occur. Okay. Frederick Mohs said, all gangrene is infected, 1941. His second paper was on partial amputations in gangrene. Okay. His first one was on using chemosurgery with mapping. Okay. He used metal salt fixation and general antiseptics. There were no antibiotics in those days. And he expected a granulating base by day 10. There were no vascular studies then either. If the granulation did not occur, if the tissue did not respond, it was straight to amputation. Okay? Now, by mapping, he literally mapped out, and when he would excise an ulcer or cancer, he would make a map, and where did it go? And he would keep treating it until it was completely treated. Here's a picture from his paper showing a gangrenous toe. And I don't know if you can read this. It says level of amputation 24 hours, level of fixation. So he fixed it and he amputated it, and then he applied fixative again. And some of that would fix down to a certain level. Day 2, he excised it again. Day 3, he excised it again. So he would fix and then debride the next day. He would do this several days in a row, 2, 3, 4, however many days in a row. He treated them every day. And then he applied his dye and let them heal. Okay? Now, by mapping, he would trace out every gangrenous sinus, because these things tend to have roots. They'll track down along bone, tendon sheath, and so on. Okay, this is Fred Mohs, 1941. Okay, now we're going to get to the scientific part. I have 10 minutes left. Glucoses of 400 to 600 milligrams per deciliter. We would give the animals streptozotocin, and in 21 days you'd see visible skin atrophy with that kind of. The skin would lose 40% of its thickness in 21 days. These animals are starving. They can't get glucose into their cells. Their cells are sick. And sick healing results in a thin, weak, gaping scars with little collagen. They also have elevated collagenases, especially MMP9. Okay? And these cells are less motile, less contractile. Let's see what that, I think this is, okay, so here's the results. To repeat that, we used streptozotocin 3 weeks before. We treated them only for 14 days. The first 14 days with either petrolatum or 1% doxycycline. And then the animals were sacrificed at day 28, and collagenases were assayed, collagen was assayed biochemically, and then histopathologically. But the results were pretty clear. All the diabetic wounds, these acute wounds, were 100% reepithelialized. Now, they weren't perfect wounds. Let's take a look. The point is, non-healing has a cause. And in these non-infected, diabetic young animals, all these would heal. Now, let's take a slide through that. This is at day 28. This is a trichrome. The epidermis is up here, hair follicles. All the red structures are either epidermis, hair follicles, or the skeletal muscle. The blue structures are in collagen. So here's the normal dermis, and you can outline the wound right here in cross-section. Okay? The diabetic wounds are gaping. They're depressed. This is quite thin, and the collagen is only half of what it is in the normal wound. Put them on top of each other. These wounds averaged 1.1 in the normals. So it contracts from 6 millimeters down to 1 millimeter. There's a lot of contraction in these wounds. But in the diabetics, 2.9 millimeters, almost 3 times as wide. Same data. The question is, can diabetic healing be modified with collagenase inhibitors? And I'll show you 2 of them in a minute. So what about treatment? Can you treat diabetic healing? Well, we used 1% doxycycline. It went from 6 millimeters down to 2.1, somewhere in between. Okay? The collagenases were less in those, and there was nearly as much collagen as in the normals. So one of the things that happens is this thinness to the scar. These are weak scars. Look how thick this one is, and this one. These fill up completely, but this one, the diabetics do not. This is untreated diabetes. Okay. Collagenase inhibitors, you can use them topically. You can use them low dose. Low dose tetracyclines have an inhibitory effect. Even if they have, if they're in sub-antimicrobial levels, or if you use a tetracycline that has no antimicrobial properties. There are substituted tetracyclines that will do that. Curcumin. There was 10,000 papers last year on curcumin and wound healing and all kinds of stuff. This is probably going to be something good, because curcumin, as it turns out, is almost exactly 1/2 of a doxycycline molecule. Instead of a tetracycline molecule, it's a dicycline molecule. But otherwise, they're quite similar. Okay, we're going to look at atrophy of normal skin in diabetes mellitus. The collagenases are elevated, the nerves are atrophied, the hair is absent, and I've got 5 minutes and 45 seconds. This is atrophic skin right next to a lesion, but I want to show you this cigarette paper wrinkling. The dermis becomes thin, the vessels become prominent. The epidermis becomes thin, and the vessels, again, are prominent. And these vessels have thickened basement membranes that are reduplicated. That's one of the major pathologies. If we look at vascular disease in diabetes, it's either large vessel or atherosclerosis, or the microvascular disease, and it affects all these organs. Tobacco makes all these worse. How about alcohol? Mild to moderate alcohol consumption has a positive protective effect on myocardial infarction, but not stroke. This is from the journal Atherosclerosis 1 year ago. In microvascular disease, look at these odds ratios, 0.6, 0.6, 0.36. These are favorable ratios. Improved, less retinopathy, less neuropathy, less macroalbuminemia. Now, what some people call moderate, 2 to 5 drinks a week, other people might call breakfast. So you turn an alcoholic loose you don't know how they're going to take it. But in general, there's no medical indication to say they absolutely can't. Okay? And these guys will negotiate everything with you. Okay, alcohol pathology, it lowers the interocular pressure, helps all the microvascular, but stroke is still a risk. So here are the vessels in the microangiopathy. Okay, let's look at necrobiosis lipoidica diabeticorum. In here, you see there's an infiltrate, and you can't really see too much. What you look, there are granulomas in here. And if we do a histiocyte stain, the granulomas tend to follow vessels. In fact, here's one around a vessel. Here's the vessel. Here's endothelial. But it's also around this nerve up here. And that's the basic pathology in the inflammatory stage. Let's look at the clinical, because these sometimes ulcerate. There's usually a yellow zone in the center, and it oftentimes becomes white. Okay, but the more active phases are red at the periphery. There's oftentimes striking atrophy. And look at this microvascular disease. If you looked in the retina and saw these vessels, you'd say that's microangiopathy. Okay, microangiopathy. Look at these on the leg. Tremendous atrophy. Okay, white centers. This all comes from a site. This is the New Zealand Dermatology Society, dermnet.com. It's a free site, and you can look at these images. They have a number of good images on diabetes. This was put together by a friend of mine, so I used it. Ulceration in necrobiosis lipoidica. Okay, so in summary, it's about 3 times more common in women. It's a microvascular disease with granulomas, arises in atrophic skin, almost exclusively in DM. It's almost a reportable case. In fact, in 1965, someone did report a case of a necrobiosis lipoidica diabeticorum. And if you see it in a patient who's not diabetic, what should you do? Work them up for diabetes, absolutely. Sometimes that's how they present, is with necrobiosis. Slow healing to a white scar, and the differential would be morphea. Let's talk about neuropathy. I have 2 minutes left. Normal, epidermis this thick, diabetic. Normal nerves, no nerves. There's cutaneous atrophy and nerve fiber loss. Can it be treated? Well, this is one patient treated for a year. The epidermis became about twice normal thickness, and there were nerve fibers again. So maybe there's hope for these. I don't know. This is a tough battle. Same nerve fiber. Experimental denervation impairs wound healing, and it doesn't matter whether it's in ligaments, tendons. There's delayed healing with denervation or neuropathy, even outside of diabetes. And it seems to be a loss of substance P and calcitonin gene-related peptide. Okay. I'm getting close to the end. Cellular proliferation is where the power to heal comes from. You have to repair the dermis by this proliferation. You have to allow that to heal. You have to get that to heal. And debridement, to manage this, is important because it re-injures granulation tissue, and bleeding brings fresh growth factors and new proliferation. Okay. These are general causes. I said full thickness injury, burns worse. There are specific causes. We mentioned cancer, foreign body. I'll make a mention of cotton fibers because I don't like cotton fibers. I don't even like them in my laboratory. I won't even paint ink on the tissues with it because the cotton fibers stick to the tissue. So I have a preference that you avoid cotton fibers, but there are all kinds of polyester things that you can use to apply medicines with and not cotton-tipped applicators. A wooden stick is better than a cotton-tipped applicator. So debridement causes granulation tissue to grow anew. Fibrin and new growth factors come to the healing site and send tissue to pathology. Any questions? I think we're done.